Hi everyone, and welcome to part 2 of our respiratory lecture series, and this is acute lower respiratory health deviations. You can basically pause on here to look at these, but just a little review of the anatomy and physiology and what's going on in that chest wall. This is for everything that's below the larynx, right? So as we continue down in the bifurcation of the lungs, so reminder about pulmonary circulation, about the arteries and the capillaries. What's involved in the chest cavity. So we have our parietal pleura, our visceral pleura, and then in between those, there's that pleural fluid, which provides lubrication and kind of prevents friction and allows expansion. Compliance is the ability of the lungs to stretch and expand. And you learned a lot of chronic disorders that can affect compliance. And under respiratory, we start to think more about the acute disorders. So if we can't stretch enough, we can't oxygenate. And if we're overstretched, then it's hard for the lungs to then let their air out, end up with air trapping. So we will spend most of our time talking about those disorders which cause decreased compliance. So pneumonia, pneumothorax, pulmonary edema, ARDS. So that's where we'll take off here. Okay, so chest pain can have many sources. One of the most common complaints that people have is a pleurisy. The thing is, when somebody comes in complaining of chest pain, we often think it's cardiac, but sometimes it's not. There's a lot of different reasons somebody could have chest pain. So pleurisy is basically a result of inflamed pleura, and one of the treatments for pleurisy is to have them lay on their affected side because it kind of makes a built-in splint and reduces the friction. As we continue on here, some of the things that we need to kind of discuss when we talk about respiratory status is the pulse ox. So these are some of the easy screening things that we do. So normal pulse ox is from 94 to 100. We consider anything under 90% that tissues are not receiving enough oxygen. This can differ based on the patient's underlying comorbidities. So, for example, somebody who has COPD, we often allow them to have a lower pulse ox, right? Because those folks are working off the hypoxic drive. People with ALS, we often want them to have a bit of a higher pulse ox, and they're considered to be hypoxic at like under 95, I believe. And this is because of the diaphragm issues. So pulse ox is only as good as the vein that we're looking at, right? So in the event that somebody has cold hands, we know that their pulse ox isn't as accurate. So anybody's got low perfusion, right? Some people's got sepsis. It can even be affected by people who have anemia and hypercapnia. But in general, it remains a mainstay of diagnosis and treatment and monitoring. So just know your normals and what can affect it. If we can't get a pulse ox on a finger, then we might have to go to a nose, an earlobe. I put them on, we wrap them on babies' feet. But understand that the most accurate is going to be the arterial blood gas. So bear that in mind. If we're concerned about somebody's oxygenation, the best thing to do is get the blood gas. And then the chest x-ray, a very common tool that we use. It will show fluid, it will show air, show the bones. But as far as anything else, though, CT is the way to go. This isn't going to show you any vasculature issues, anything like that. So speaking of blood draws and blood gases, so this is a difference between what we would see on an arterial blood gas and then a venous blood gas. Now, of course, the arterial would be the one that would be the most accurate for us, and you can see those normals there. You guys should have learned these already. And then look at the venous on the other side. So pretty similar pH. I mean, a little more closed of a window because it's deoxygenated. But look, we allow for more CO2 and less oxygen for sure. Bicarb, generally the same range, but the venous oxygen 60 to 80%. So we know that that blood is deoxygenated, and that's why these different values. When in doubt, if you don't know whether you've got an arterial or venous blood gas, you should when you draw them, and that's a special skill you'll be taught if you need it. But in general, when the blood comes out of the artery, it actually fills up the tube rather easily. You can see the pulses of the heart. The color looks very, very bright, and venous is darker because it's deoxygenated. In order to do an arterial blood gas, you do need to do the Allen test to confirm that they have circulation to their hand. Basically, what we're doing is we're looking for collateral circulation. And this means that in the event that we were to cause a blood clot or other problem with the artery that we are using to obtain our sample, that the hand would still have blood flow to it. They do these preoperatively for free flaps and all sorts of things, but commonly done at the bedside to make sure before we do a blood gas that we can actually not cause harm to the patient. So basically what we do is we pinch the radial and ulnar arteries, have the patient squeeze their hand a few times. Now that hand should blanch. And then we let the ulnar artery go while we keep the radial artery blocked off. And we check to see if the color returns to the hand. If it does not, right, you have about 6 seconds. If it does not, then you should not use that radial artery for your blood gas, which means go check the other side, potentially use a brachial stick or femoral. Let me go back here and fix that up. When we suspect some sort of disorder for our patients, then we also can do CTs and MRIs. These are going to be rather mainstays, especially if we're looking for issues with the vasculature, so PEs and basically some of our cancers, things like that. So look at the nursing care. Understand that CT that uses dye can cause acute renal failure, so it may not be indicated in our patients who already have renal disease, or they may need to have dialysis right after. It depends on how important the scan is, but many times we'll just do them without contrast if at all possible. And then MRI, this is a giant magnet, which will pull magnet. We've had people who weren't truthful about some of their stuff that they had. Like, for example, we had somebody who had some shrapnel. Maybe he wasn't not truthful, maybe he just forgot, I don't know, but it really will pull them out of the body because that magnet is so strong. So the VQ scan is a pretty important scan for us as far as looking for pulmonary embolism. So basically, it's a two-step process, one in which that they inject an isotope to see the vasculature, and then they also breathe it in. So basically they have oxygen and that radioactive gas, and they breathe it in, and then they're able to see where the circulation is and then where the ventilation is. And for example, if we have good ventilation but not circulation, so perfusion, then that would rule them in for a pulmonary embolism. And because this doesn't use CT dye for those people with renal disease that we suspect a PE, the VQ scan may be appropriate for them. Gallium scan basically stages bronchogenic cancer. And at this, they're getting gallium, and they have to go every few hours, like at 6 hours, 24, 48. that look at how much of that gallium is being uptaken, and then a PET scan. PET scan is very common that once we have an initial diagnosis of cancer, then we can use a PET scan to further identify areas of concern and look for mets. You have here a flexible bronchoscopy. This is a very common procedure. It's usually done on an outpatient basis where the doctor will go down with a camera and a little arm there, as you can see, to grab samples. So basically it's direct visualization. The person does need to sign informed consent for this. They are under conscious sedation. And if you look at it, we're taking their airway and going down in there. So they have to be NPO for, at least 8 hours prior to this. So they usually say like at midnight the night before. And you must check their gag reflex before feeding them or giving them anything to drink, or else they will aspirate. Minor bleeding can be expected from this. So things like blood-tinged sputum, right? We might expect that after. However, we do not expect them to have a massive amount of bleeding, blood clots. You need to always be concerned about their airway after. And then down here, some of the other reasons that we may do this bronchoscopy is somebody has a foreign body, so somebody who's choking, they can go down and get it. We use flexible bronchoscopy and lavaging for people who have burns, and airway burns as a means of washing out their bronchi. They can even do some surgical procedures through there. So again, the priorities are going to be, of course, their airway, bleeding, making sure they have their gag reflex. The next one we have here is a thoracoscopy. I don't know why this is always moves on me every time I try and record these. That's okay. So the thoracoscopy or thoracoscopy. Basically, you can see here, this is what we saw before. It's a VATS, and what do we expect to see here? I mean, think about this. Anytime we're going into somebody's chest like this, we're giving them a pneumothorax, right? Because we're entering that space. So we usually expect chest tubes and monitoring them for worsening pneumothorax. So if they become short of breath, we always have these guys on cardiac monitor after surgery. And that's always a possibility too for something like a flexible bronchoscopy, that the doctor could actually cause a pneumothorax as well. So throughout your reading about pneumothorax, if we cause it, it's called iatrogenic, which means caused by healthcare. Don't let them fool you. That means we did it. All right, so thoracentesis. This is a very common procedure, so one that you need to be acutely aware of. So basically, the reason we do a thoracentesis is to get the fluid out of a lung in the pleural space. So not in the lung, right? It's in the pleural space. So that's very important to remember what it does, why we're doing it. All right, a lot of times it's to drain a pleural effusion. In that same vein, we might have to do cytology on it. In the case of malignant pleural effusions, it could be cancerous. If somebody has fluid in their pleural space, then they're likely having decreased lung expansion. So things to know about thoracentesis. Absolutely the positioning. There has not been any review that I've ever seen that doesn't ask you about thoracentesis positioning. So here's a picture for you. The patient should be sitting upright, leaning on a table. And in this, basically the doctor, and they say often done at the bedside, The doctor will insert a needle and withdraw the fluid by a syringe, or conversely, they can insert a tunneled catheter and leave it in place. If by chance this person isn't able to sit up, they could lie on their unaffected side and be in position that way, but ideally the person should sit up at the side of the bed and present their back to the doctor by placing their arms on the over the bed table. So some of the concerns about folks who have this procedure, so if we take out large quantities of fluid, this can cause a circulation shift into the pleural space. So what does that mean, right? If the circulation kind of moves in that direction, the person's going to present as decreased blood pressure, tachycardia. They may need to have fluids to restore their volume. As far as our patient teaching and our monitoring, it is normal that people will have pain with this procedure. We do use a local anesthetic, but then afterwards, like their breathing might be a little painful. There should be some drainage on the dressing. If there's a dressing left behind, that's perfectly okay, serosanguinous. They may even complain of some chest pain. What we will not see or should not see, again, are changes in vital signs to be worse. And also, we should not see them frankly coughing up blood, because when we go into the lungs here, remember, we're not going into the lungs, but rather into the pleural space. There should be no communication with that lung tissue at all. So if the person starts coughing up blood, or hemoptysis as it's called, then what we know is that somehow they've gone further and from the pleural space into the lung. And this person would also be at risk for development of a pneumothorax as well. Okay, so a little nod to oxygen toxicity. I'm sure that you guys learned all about oxygen toxicity and how important it is not to give too much oxygen to a patient, because if they have COPD, you can make them stop breathing. So I want you to be aware here that we do care about oxygen toxicity as well. However, our concern for it is a little bit different than the COPD person. The one thing I want to make clear is that in the event of somebody in respiratory distress, we will not be withholding oxygen, okay? Because we want to make sure that we're treating those life threats first. So if somebody, I don't care if they have COPD or any other number of letters together, if they are acutely short of breath and they're hypoxic, we must give them the oxygen. The concern we have here is oxygen toxicity for us would be too high of an oxygen concentration, so greater than 60% oxygen given for over 48 hours. So that is our definition of oxygen toxicity. Remember, too much oxygen can damage our cells. And you can see the signs and symptoms here. If they have oxygen toxicity, that's what we might see. So we need to reduce the oxygen concentration if that's the case. So this is always our goal, is to give the person the least amount of oxygen that's effective. So how can we do this, right? This is where PEEP comes into play. The higher the PEEP, the lower the oxygen can go generally, right? So as we add more PEEP, we can kind of move some oxygen, because the PEEP forces alveolar compliance. And then CPAP can allow less oxygen to be used, and the reference is there for you for the 11th edition. All right, so CPAP and BiPAP are two different modalities for delivering therapy to our patients. We do use these. Ambulances are now able to use CPAP if they're certified. We might use CPAP initially, and then if that's not working, we go to BiPAP. Basically, it allows us to delay or even avoid intubation. We're commonly seeing CPAP being used at home for people with sleep apnea. We also use it to end-of-life care if the patient will accept it. It's good for those folks who need ventilatory support, but they refuse to be intubated. So this is considered non-invasive positive pressure ventilation. So ways we would not want to use this. So contraindications include those who are not breathing. I know it sounds silly to say it out loud, but if somebody is not breathing, please do not place them on BiPAP. It will not help. Anybody who has a serious dysrhythmia, they're altered. Little advisement on that, though. Altered mental status, yes, is a contraindication, but sometimes it's also the indication for BiPAP. And anybody who has head and facial trauma, because these machines can be rather tight, and you don't want to cause increased trauma to them. Okay, so the difference between CPAP and BiPAP is that CPAP just gives the pressure. It's set that way, and it will just deliver that. Again, person must breathe independently. Same thing with the BiPAP. The difference with the BiPAP is that it allows for 2 levels of pressure. So one for inspiration and one for expiration. So that's called the IPAP and the EPAP. So basically, this is better for blowing off the person's CO2. So this is what we use for people who have acute COPD exacerbations and respiratory failure. Okay, so the next thing we're going to talk about is pneumonia. There are a couple different pneumonias that we concern ourselves with. Of course, community-acquired pneumonia, people are coming in with it. Not much we can do as nurses to prevent that one. However, what we can do is help prevent hospital-acquired pneumonia and ventilator-associated pneumonia. So there are things that we do that we never even think about as pneumonia prevention. But washing our hands, right? Number one thing for infection control is always to wash your hands. It is basic. Turning, coughing, deep breathing, using the incentive spirometer, turning and positioning, getting our patients out of bed and walking them, elevating the head of the bed, decreasing sedation, right? So people can cough up secretions and breathe a little more normally and expand their lungs. Another type of pneumonia that we have is aspiration pneumonia. And aspiration is due to basically a depressed cough. So for one reason or another, the person may have some difficulty with their swallowing, or they're unable to effectively clear their airway. So they couldn't protect or clear it. So folks with trachs as well, any alteration in the airway. So remember, if they have tube feeds, they have to have the head of the bed elevated at least 30 degrees. We check their tube placement and residual volume. Some say even, absolutely before each feeding, but what about continuous feeds, right? So at least every 4 hours. We may need to give them medications, of which we've talked about some under the cancer section. So things like antiemetics and gastric motility agents, those that increase the emptying of the gastric contents. Anybody who has an airway or at risk for aspiration issue, they should have suction readily available. All right, so pleurisy, we talked about that in the beginning. So inflammation of the parietal visceral pleura. So when they have the pain, it's coming from the parietal pleura. The patient, when they have pleurisy, they will complain of like a sharp stabbing pain, usually one-sided, and it gets worse on inspiration. So if it's inflammation, NSAIDs will generally work, so indomethacin, and again, splinting and turning them on that affected side to reduce the expansion. That's all that's needed there. And then, of course, treat the underlying cause. And here we'll talk about a pleural effusion. So pleural effusions can be either transudate or exudate. So basically, if it's thin and watery versus an actual bacterial infection or malignant from a tumor. You can see the X-ray there shows that layering out of the air fluid line. if we were to percuss the patient, we would hear a dull percussion. So remember, air gives you hyperresonance and fluids would give you dull resonance. So, and then there's also a role for tactile fremitus, which is something that you guys should have learned in your initial courses. So basically that's where you're having the patient say 99 and you're trying to see how the vibrations are transmitted across the lungs. So anything that increases the space between the lungs and you listening can cause decreased fremitus, and things that cause a decreasing space would cause increase. So consolidation in the form of pneumonia might cause that. Pneumothorax would decrease it. Pleural effusions would probably decrease it, right, because you're putting an extra space between the lungs. And empyema is a lung infection as well. So this is thick fluid that's in the pleural space. Does come from bacterial pneumonias and comes from abscesses. Basically, the exudate kind of goes in there from the lungs, okay? Some other reasons that somebody might get an empyema would be chest trauma. We might have done it, iatrogenic. So signs and symptoms are listed here. They have fever, night sweats, cough, shortness of breath. How do we treat it? So you can see the dullness on percussion, decreased breath sounds. So it's treated with a long-term course of IV antibiotics. We may need to do a aspiration or even a chest tube. If we cannot heal the empyema, it's possible that we have to do a thoracotomy to remove the diseased tissue. So basically, empyemas are absolutely no fun for the patients. It's a long-term course and often results in a longer disability, right? They need IV antibiotics for quite some time. All right, let's move this over here. So what is a pleurodesis? So it's basically when a chemical irritant is placed between the pleural layers that decreases the pleural space to prevent pleural buildup. So basically what we're trying to do here is cause scarring, right? The scar tissue allows those lungs, it allows the lungs to expand because it sticks the visceral and the parietal together. So in order to do a pleurodesis, basically we have a chest tube and the chemical irritants are placed in there. It's usually some sort of a sterile talc. So that's done, and then the chest tube is clamped, or in some cases, I've seen doctors basically hang it up on the IV pole, but for NCLEX Hospital, we will always clamp it. And then we turn the patient like a little rotisserie so that we can get that talc infused and settling where it needs to be. So again, the hope is that the scarring closes the spaces. Now, if that doesn't work, then we often have to go to more invasive procedures, including wedge resections, thoracotomies, even further potential removal of that lung tissue. And as we kind of go down, let's talk about lung cancer here. So lung cancer, we talked a little bit about lung cancer under our cancer section, but I think we need to address it here as well. Of course, smoking being the #1 risk factor for lung cancers. Non-small cell lung cancers are the most common, but the most aggressive, of course, are the small cell lung cancers. So treatment does surgery, radiation, and chemo, just the same as we've talked about before. But here's something to be concerned about. So if there's any mediastinal involvement, so remember what's in our mediastinum, our heart's there, that we could end up with cardiac tamponade, pericardial effusions, and dysrhythmias. So In the event of cardiac tamponade, that's Beck's triad, which hopefully you guys have learned about. If not, I know we do address it at some point in this course, but that's what we may see. And then, of course, there are things that go along with some of our lung cancers, this paraneoplastic syndrome. So basically, those cytokines are messengers, enzymes, and antibodies. They tend to destroy some healthy cells. So when we talked about an oncological emergency of syndrome of inappropriate antidiuretic hormone secretion, one of the main risk factors is that small cell lung cancer. And sometimes these things in the paraneoplastic syndromes, they show up long before the cancer does. So basically, I think it's just important to know that like Cushing syndrome can be a result of these lung cancers. What else is on here? Like, you can pause and take a look at these. I put some of the most common and what causes it. So people who have things like polycythemia, it's because of too much erythropoietin. But for us, when we talk about lung cancer, we're concerned with SIADH, hypercalcemia, and Cushing syndrome. And just like we talked about with cancer, targeted therapy can be used to block tumor growth. And targeted therapy, if we can do targeted, is preferred because it's less toxic. And then some of the other things we do, so tyrosine kinase inhibitors, and I believe those are the ones that end with NIBs, and then angiogenesis inhibitors. So those ones would stop the vessels growing. Again, those can also cause clotting and other problems whenever we start messing with our vessels and our red blood cells. So let's talk about a lobectomy. This is a pretty common surgery. We try to do more tissue sparing these days, but lobectomies are still going to be seen definitely much more often than a pneumonectomy. Oh, you can see there's different types of surgeries on the right-hand side of here. The most tissue sparing would be the just getting the wedge out. So they take a little spot of the lung around the mass, and then they might have to take a segment, possible lobectomy. So they take the whole lobe, and then in a pneumonectomy, they actually take the whole side of the lung. So things to think about. One is that anytime we go in and do any of these surgeries, we are causing a pneumothorax. So with 3 of these surgeries, they will always have a chest tube. So the wedge, the segment, and the lobectomy will have a chest tube, sometimes 2 chest tubes. So if they do have 2, one would be placed in the upper position to collect air, and one more inferior to collect fluid. And if they're just having a lobectomy, segment, or wedge, the person can lay on any side, right? There's no activity restrictions as far as that goes. So the issue comes in when we have a pneumonectomy, right? So pneumonectomy, as you recall from the previous picture, is the removal of the entire lung. And this happens, if the cancer is large, if it's based on where it's located. And we do this for more than cancer. We may do it for tuberculosis, abscesses that we can't heal. It is more dangerous to take out the right than the left because of, think about it, the left has 2 lobes and the right has 3, so definitely more vasculature there. And they usually would have no drains, no chest tube, right? We need the person to have an accumulation of the fluid to prevent that mediastinal shift. And our postoperative care, so let's keep going on here. We'll do pre-op and post-op. So pre-op is definitely let the patient know that they're going to be in ICU. They need the ventilator post-op. That as they get better, they'll start to move up to the regular floor. That we will control their pain. pain is expected, that they may need blood products. So just normal pre-op teaching, right? Let them know what to expect. And then for us, for the care, let me move this over so we can see. We know that if we're removing a lung, then they have decreased lung capacity. We do keep our IV fluids at the lower rate because we do not want to cause pulmonary edema. Keep the head of the bed up 30 to 45 degrees once they're stabilized. We want to keep the remaining lung in the uppermost position, so good side up. So if the left lung was removed, then the right side should be up, right? So good lung up, good side up. This is different than some of our pneumonia teaching. Our pneumonia teacher says good lung down. So good lung up for these guys. All right, these guys usually have an epidural. They need to work on their lung expansion, range of motion, monitor them for infection, and then they may need also ventilator care. So just little helpful hints there. Next, we're going to talk about chest trauma. A person can sustain chest trauma either through blunt or penetrating means, sometimes both, right? So penetration would be things like a stab wound, gunshot wound, something impaling them. And blunt would be, of course, blunt force. So anytime we have somebody who has a chest trauma, we always want to be concerned about their airways, breathing, and circulation. Potential that they would need to be mechanically ventilated. Some of the things that you'll see are things like paradoxical chest wall motion. It's very important that you understand what that is and what it means. If there's any shift in the trachea from its normal midline position, that could be a sign of tension pneumothorax. Listening to their breath sounds becomes very important because anybody who has a hemo or pneumothorax will have decreased breath sounds. Management of these patients does include making sure they have at least 2 IV access to large bore IVs, and that we may have to give them fluids, including blood products. Labs would be type and cross. We do chest x-rays, potentially CTs. We need blood gases, heart monitoring, right, and ultrasounds potentially. Remember to completely undress your patient so that you do not miss any wounds, and you're looking for entry and exit and any impaled objects. Distended neck veins, just coming back to that should be under the assessment section. If a person is bleeding, we would expect to see flat veins, but distended could also mean that you have a big problem above too with some shunting. Subcutaneous emphysema means that there is air under the skin where it doesn't belong, and that is a sign of potentially a pneumo and barotrauma, so lung injury, bruising potential. Always want to check their peripheral pulses to make sure they're not going into shock. Foleys may be needed for shock management as well, nasogastric tubes, and then chest tubes to monitor the intrathoracic bleeding. So anytime somebody has an open wound like that, an open pneumothorax, the treatment for it is to apply the 3-sided dressing. So what we do with that is you put the occlusive dressing over it, and then you tape up 3 sides and you leave one open. So basically, as the patient breathes in, it blocks them from sucking the air in, and then as they breathe out, it allows the air to escape, and that prevents the buildup into a tension pneumo. And I think we may talk about this later, but the 3-sided dressing, very important. We're more likely to get a sternal fracture through things like massive trauma. You've got to think how strong that bone is. So motor vehicle crashes where people are hitting the front of the car and way of the dashboard or their steering wheel. If they have flail chest, we'll talk about that in a minute. And some of the things they might complain about would be interior chest pain, that you'll see bruising, feel the crepitus. They may have a chest wall deformity. Think about what's under the ribs and where they're located as to what may be damaged by this. So ribs 5 through 9, those are the ones that are not as large as 1 through 3. And these are the ones that underneath are lying our liver and our spleen. So these people often will have like a spleen laceration, liver laceration. Very hard to break ribs 1 through 3. But if you do that through that blunt trauma, there's a lot of vasculature that's through there, including the subclavian artery, and people can bleed out pretty quickly. And our older folks do not tend to do as well with rib fractures. So if they have at least 3 rib fractures, they're more than 5 times likely to die from it. So some of the complications from our rib fractures really is pneumonia. So, I mean, outside of the initial life threats, but they tend to get pneumonia because this is very, very painful. And if that's the case, people tend not to breathe as deep, which leads to atelectasis, and then of course the bacteria come, and a person dies of atelectasis and pneumonia. So there's we used to, I say, kill them with kindness. We used to splint their rib fractures, and it would be very comfortable, but again, increased mortality. So now we don't generally splint rib fractures anymore. It's no longer recommended, but instead we need to make sure we're giving these people adequate pain control and encouraging that incentive spirometer, right? Even when they leave the hospital, they need to take it with them. They need to keep doing it at home. Flail chest is a type of rib fractures where you have at least 3 adjacent ribs fractured at least 2 sites. Basically, what happens here is now you have a free agent, right? We've got this rib segments that are floating around. They can actually work as a sharp object, and additionally, they can no longer expand that part of the lung, right? Because you need those ribs to be moving in unison to provide that. And that causes that paradoxical chest wall motion and paradoxical movement. So basically, when they breathe in, that rib gets sucked in, and when they breathe out, the rib section bulges out, and that causes them to have increased work of breathing. They're usually in extremis. They are short of breath, dyspneic. If it's bad enough, they may need to have intubation and surgery. Priority is to stop that piece from flailing, so they may need to have that put back in order. And one of the other things is that we need to be concerned about with chest trauma is, and the flail chest, but chest trauma in general, is a pulmonary contusion. If a person has a pulmonary contusion, we may not see that right away, right? Because think about a bruise inside the lungs. So the bruising can eventually lead to problems later on. We may not, like we hit our arm, we don't see a bruise for several hours. Same thing with the lungs. We may hit the lungs and not have that bruising occur for several hours. So what we would see is after the initial injury, we would then see the signs of shortness of breath. This is not something we can see from the outside, right? So we need to be aware and continue to monitor our patients who have sustained trauma. And then this just shows you the mechanism of a flail chest, and you can see that paradoxical movement. I encourage you guys to watch the video and see what it looks like. So one of the dangers, of course, is the pneumothorax, which we've sort of talked about already. So pneumothorax can be caused by trauma, or it can be spontaneous. So the questions we need to ask ourselves is, what's the cause? So patho really is the air entering the pleural cavity. Could be due to, they say, due to trauma, and it's either going to be open or closed, right? So open means that there is an opening in the chest wall. These are the sucking chest wounds. They literally make that sound as if the air is sucking through. And under closed, there's no external wound. So these would be perhaps caused by, let's say, somebody had a bronchoscopy. That would be a closed pneumothorax. Somebody who has an emphysematous bleb that ruptures, that would be closed. The one that's, of course, the most dangerous would be the closed, because there's nowhere for the air to go. That can lead to a tension pneumothorax. And for us, the hallmark sign is going to be the decreased breath sounds, right? Diminished or absent breath sounds over the place where the pneumothorax is. So just a reminder there that what the pneumothorax is, that it can be open or closed. If we have an open pneumothorax, it is appropriate to put that 3-sided dressing on the patient. And if it's closed, we would need to have a chest tube inserted, or a needle decompression if they had a tension pneumo. All right, so I say this just kind of backs up a little, but the signs and symptoms we see on a pneumo really depend on how big the pneumothorax is. So a small one, person may be completely ambulatory, heart rate increased, maybe take a little shortness of breath. But a large pneumothorax, the person will be in respiratory distress. And then there's the types, which again, we've already kind of addressed. So it's just written there for you. You see here our open pneumothorax and the treatment. You see that 3-sided dress that gives you that flutter valve. Tension pneumothorax is a medical emergency, and this is what we'll see in the patient: severe dyspnea, tachycardia. Hallmarks for you guys: tracheal deviation, right? That's a hallmark there. So anytime we see tracheal deviation, you're going to want to act quickly to make sure that we relieve it. So either by chest tube or needle decompression. Neck vein distension could be seen in the tension pneumo. And here you have another representation of it, the mediastinal shift. So you have tracheal deviation away from the side that's affected. Concerns here would be that of decreased cardiac output due to decreased return to the right side of the heart, right? So if we can't squeeze in, we can't let out. So venous return is affected, and we know the veins go to the right side of the heart, not the left, and that causes decreased output. And so here is the treatment. So emergency treatment: open pneumos, cover them, secure that dressing on the 3 sides. Be prepared to insert a chest tube. And for tension, needle decompression or a chest tube. If there is an impaled object in your patient, please do not remove it. Instead, you stabilize it with a bulky dressing and don't pull it out. So now let's start to talk about the chest tubes a little bit. That'll be our next section. Okay, so the first thing to look at is, where does the chest tube go? All right, so it goes in the intercostal space, right? So it goes between the rib cage and goes into the pleural space, and that's where it can do its magic, right? That's where it can either drain fluid or air. You may be tasked with assisting with placing a chest tube, and that's well within your scope of practice and a very common thing that you would see. So We do prefer to do them under non-emergent conditions. That would be the ideal. Doesn't always work that way, but if we can, definitely make sure we have local anesthetics and have everything set up. You need a thoracotomy tray, the chest tube. The doctor will tell you what size they want, but in general, we use smaller tubes for air, so even up to something we call like a pigtail catheter, and then larger chest tubes if we think there's going to be a lot of fluid or blood. And then positioning. We put the patient flat, wedge under the shoulder blades, even like a rolled up blanket, and then the arm that we're going to be working with over their head. All right, so, and then I also put on here where they put the needle decompression for the tension pneumo. Doesn't necessarily belong there, but kind of does, right? So remember, if we're doing something superiorly, it's to relieve air, and inferiorly would be for drainage. So you may get air and drainage from the lower ones as well. So you see here a common chest tube. This is Atrium. It's considered a name brand. So Atrium is the manufacturer. And this one is called an Ocean, but we also have things like Oasis. It's just the model. What's important to know is what the different sections are of the chest tube and what they do. And in your packet that I've created for you, if you're listening to this and don't have a packet, something I've given out in classes, you have a chest tube which you can label, and you can look and see what the different sections are, and you should know them, right? A lot of times nurses are sort of quizzed on, what's going on, and taking care of the patient depends on you knowing what's normal and abnormal. So the collection chamber is to the far right, sometimes called a trap chamber, and that's basically coming from the patient. And through there, air, so if there's air coming from like a pneumothorax, will go through there, as well as any drainage, right? Usually serosanguinous, but can be bloody. Depending on what's happening, it could even turn into that chyle, like we talked about under the head and neck cancers, where you could have that thick, milky drainage, which is significant for lymphatic leak. And then from the collection chamber, we end up going into the water seal. So there's a one-way valve there. It stops the air from going backwards up to the chest, and then it kind of, as the air moves over it, that's where you have the bubbling, right? So intermittent bubbling is good in the water seal. You may have continuous bubbling if it's just inserted, or you have a rather large pneumothorax, but it should settle down. If it doesn't, or if it starts when it wasn't there, we would consider that to be an air leak. And then we have the whole titling, so that's the next section we have where we can tidal in that area as the person breathes in and out. The ball should rise and fall with their respirations. Interestingly enough, if they're on a mechanical ventilator, it's backwards, because the ventilator is negative. It's positive pressure, not negative. And then the suction control chamber. So it depends on the type of chest tube. The ones that you see here would have you put the water in to give it to the negative pressure. Some of the other ones that aren't this type, you can just dial them. And then there's even a spot up at the top that we can hook this up to wall suction. And sometimes we need to do that to make sure that the treatment is uninterrupted and that it provides better expansion. Caring for a chest tube is going to be one of your responsibilities, so it's very important to know the do's and do nots, right? So chest tubes need to be kept lower than the level of the chest, of course, because they're draining by gravity, and we wouldn't want things to back up. You are responsible to collect and record that output as part of your output. So we do have some norms and abnormals. So over 200 mLs in the first hour, or more than 100 mLs an hour thereafter per NCLEX standards is reportable. we want to be careful not to kick the unit, break the unit. If by chance the unit breaks, then you need to restore that water seal. And we usually say put it in 2 centimeters of sterile water. We never milk or strip the chest tubes. And a little bit about titling. So we expect titling when the person is breathing, because that is like the difference in the pressures from negative to positive pressure as they breathe. However, as the patient heals and that pleural space decreases, we'll see less titling. So what to do if the patient doesn't have titling? First, make sure that there's no kinks in the tubing. Make sure you don't have it accidentally clamped or something going on. And understand that it may be a normal process. What I look at is something new, right? If somebody's been titling the whole time at 8 o'clock and then I go back for meds at 8:30 and they're no longer titling, more than likely it's not connected somehow, it's occluded, there might be something going on there. And then also mediastinal tube, we often put them to the same exact apparatus, right? So it does look like a chest tube, but you have to know where it's placed. There's no titling in the mediastinum, so you wouldn't expect to see titling. So mediastinal drains are often used post-surgeries like open hearts. So if it's not in the pleural space, it's not going to title. All right, so other care issues, we don't clamp the chest tube. Used to be we would clamp them for transferring and going to certain places. We found, we caused a tension pneumothorax when we did that. So we don't do that anymore. So the only time that we tend to clamp the chest tube is during a chest tube change of the suction canister, the collection. So that's when we clamp it, and it's very brief, and I can show you in class how brief. If by chance the person were to completely dislodge their chest tube, we then need to treat that as an open pneumothorax and apply that 3-sided dressing. Okay, a little more on chest tubes. Subcutaneous emphysema means that there's been barotrauma, right? It means that the chest tube could be dislodged. It may not be in the spot that it was. So what's the problem with subcutaneous emphysema? Is that it can impair the patient's airway. We do sometimes see a measure of subcutaneous emphysema just right around the chest tube insertion site, and you can press your fingers around it and kind of feel that it kind of pops the air underneath your fingers, and generally localized. But if subcutaneous emphysema were allowed to spread, it could go up and affect the airway. I've seen patients literally turn into the Stay Puft Marshmallow Man with all of the edema from the subcutaneous emphysema. We want to always make sure that we're taking good care of our chest tubes. When we ambulate patients, we don't have that tube wrapped around them. We carry it on, the same side that it's coming out of. Be very, very careful not to knock it over, otherwise damage it. Make sure that the patient doesn't accidentally kink that tubing when they're sitting up and down in their chairs. We never milk chest tubes. You'll see doctors doing it. We don't. And then, of course, the patient needs to turn, cough, and deep breathe as well. So we want to promote lung expansion. For us, we know it's time to take the chest tube out when the chest x-ray basically says it, right? The lungs expanded, the patient has been off of suction, they can go to water seal, and they're tolerating that well, then that would be a good indicator that they're healing. Look at me, I'm always ahead of myself. Indications for chest tube removal, here it is. So, and then this picture is kind of interesting. So this is what we call a Heimlich valve. It's a one-way valve that's just used for chest drainage. And patients can go home with these little Heimlich valves. So people have like persistent pneumos, and sometimes now we even have like portable atriums. Very interesting. People don't have to stay in the hospital as long these days as a result of some of this technology. All right, so here's just a little nod to cardiac tamponade, which, like I say, could always be a concern with any problem in the mediastinum, any of our lung cancers. You absolutely need to know this stuff, right? It's cardiac tamponade. Basically, the fluid's filling the pericardial space, which every time that happens, the heart can't beat appropriately and they can't fill. So what do you see? Decreased cardiac output. If the heart can't fill, then we see the backup of the blood into the jugular veins, and then muffled heart sounds. So Beck's triad, that's must know information. Okay, some of the last things we're going to talk about in this section will be the pulmonary embolism. So basically, a pulmonary embolism is a blockage of an artery, one or more, that basically causes that ventilation perfusion mismatch. So there are clots that travel usually from the deep veins of the legs, but can be from other places. And based on the level of occlusion is like what signs and symptoms we're going to see, how distressed the patient is. So look at some of the risk factors, right? So here we have tons of risk factors for PE. Immobility, reduced mobility, especially any surgeries within the last 3 months, especially the pelvic or lower extremity. So somebody who has like a hip replacement, knee replacement, ORIFs, anything like that. Obesity, people who are on oral contraceptions, hormone therapy, any clotting disorders, pregnancy. So the risk for getting a PE is actually pretty large. But less common causes of PE would include those fat emboli, which we'll talk about in musculoskeletal, air embolism from improperly administered IV therapy or central line removal. And the treatment for an air embolism is a little bit different, and amniotic fluid embolisms and even tumors. So here's your assessments and diagnostics. So what we're going to see in the patient really is tachycardia, dyspnea. They'll have potentially cyanosis, kind of a later sign, but depending on how large it is, they may be cyanotic. If you look in their ABG, it definitely would show some decreased aeration. If they had a massive PE, some of these are deadly right away. Person has altered mental status and hypotension. As far as labs, we do look at the D-dimer. So a D-dimer is basically degradation products of a clot. So anytime it's elevated, it means the body's breaking down clots somewhere. So what does that mean? Depends on the size of the PE. So it may not be elevated if it's just a small PE. So a negative D-dimer doesn't mean they don't have one, but a positive D-dimer means they definitely have a clot somewhere. We use that spiral CT. That's the most common, and that uses the contrast. And if not, we would use that ventilation perfusion scan, which we talked about earlier in this presentation. So treatment, right? Treatment is to, immediate care is to take care of the patient, right? Sit them up, get that oxygen on them. It's a little different than air embolism treatment. Air embolism, we wouldn't want to sit the patient up. And reasons are, of course, air would rise and could actually worsen. But for signs of a pulmonary embolism, sit them up, get that oxygen on them, and we may need to treat them for shock. An initial treatment for most patients is anticoagulation, usually with Lovenox or a heparin drip, putting them on Coumadin. If it's a massive PE, we may need to actually break up the clot. They might have to go in and actually remove the clot with an embolectomy. And then IVC filter is more of a preventative for people with known DVTs or who cannot have anticoagulation. So little nod to anticoagulants is that basically, they're pretty dangerous, right? Somebody who's on a heparin drip, we need to monitor them so carefully because of the risk for bleeding, and then also the risk for heparin-induced thrombocytopenia syndrome. So our NOACs are now called DOACs. We'll talk about that. I still keep the old terminology because you might see a doctor talk about the NOACs. But aspirin and Plavix are not total anticoagulants. What they are antiplatelet aggregators. So, but they can lead to bleeding because it keeps you from letting your platelets stick together. So those are the meds. They are kind of must-know meds. So let's talk about heparin. The first thing I do want to back up and say that when we're treating these blood clots, these PEs, outside of actually going in and doing fibrinolysis or an embolectomy, we're not actually treating the clot that's already there. What we're doing is preventing the body from enlarging that clot and making more. So heparin can prevent that. It starts immediately. We give it to them. We usually give them a bolus dose if we're doing a heparin drip, weight-based. And we may do a continuous infusion. And remember, anything that can cause, that's like an anticoagulant, can cause bleeding, so always be mindful. We monitor this with the PTT. Newer and most direct action of heparin is monitored by the anti-factor 10A, so anti-XA you'll often hear, and monitoring their platelets. We need their platelets to not drop, because if their platelets drop, we are concerned about heparin-induced thrombocytopenia. There is an antidote for heparin, and anytime there's a med that has an antidote, you would be wise to remember it. A Lovenox is heparin. It's just a low molecular weight heparin, so do not be confused. A person with an allergy to heparin is also allergic to Lovenox. They cannot have that ever. But Lovenox is decent because it can bridge Coumadin. People can go home and take Lovenox. It's basically has the same reversal agent, and it's used in pregnancy and elderly. It's a little bit easier. They say do it at home, and it doesn't require lab values to monitor it as much as something like heparin or warfarin does. So usual dose, 1 milligram per kilogram every 12 hours. Most normal adults will take a 40 milligram dose. Subcutaneous twice a day. Sometimes even once a day now, depending on if it's just preventative. But if they're being treated for a blood clot, it would be twice a day. And then warfarin, which was very interesting. If you ever want to nerd out or something, go look at how warfarin was created and introduced and sold and everything. But so warfarin, it takes about 36 to 72 hours to start working, and then to be therapeutic 5 to 7 days. This is why we tend to bridge people with Lovenox as they start on warfarin. For this, we do monitor the PT-INR. So the INR is what we base our dosing off of. Generally, we want that INR between like 2 and 3 for most folks, and those with mechanical heart valves, we keep them a little thinner, like 2.5 to 3.5. Antidote is vitamin K. So this is why diet is so important with these people. Used to be like, they say, like, don't take any vitamin K containing foods, like keep them decreased. We're more patient-centric now. So basically we say that if they eat green leafies every day, then they should continue to eat them every day, because otherwise they could inadvertently deactivate their warfarin. The one thing I've noticed is as people get sick, their INR tends to go up. It's just a very interesting thing. I think it probably has to do with how it's metabolized when we have inflammation and the different cascading, like our intrinsic pathways. But it's pretty interesting. So always watching for signs of bleeding. These are the folks that if they fall and bump their head, they need to have CTs, right? We are very concerned about them. All right, so let me move this over. Again, I have no idea why it does this on some slides and not the other, but it is what it is. So, Plavix is, again, we use this after stenting. It's a platelet aggregation inhibitor. We don't usually see it as prevention of CVA for like just CVA itself. It's people who have stenting, so people who have had surgeries on their legs to restore circulation, people who have stents in their heart. We'll see it for that. And then the again, they call them new oral. They're not called that anymore. They're now called DOACs, or direct oral anticoagulants. These meds are great meds in that they don't require monitoring. They actively work on factor 10. They're coming down in price. When they came out, they were very expensive. But the other issue is that there's no antidote to these. So if there is a problem with this, somebody needs surgery, whatever, we have to really, or they have a reaction, we have to really support them through it until the medication wears off. Again, there's no antidote. Okay, and I guess the last thing we'll talk about in this section is the Greenfield filter. It's falling out of favor these days, so we don't see them that often, but you may still see them, and patients may have them, so you should know about them. Basically, it's a filter that's placed in the IVC, and that basically collect clots so that they wouldn't travel up and become pulmonary emboli or into the brain. So anybody who can't have anticoagulation, this would potentially be the procedure for them. The problem is that if you can look at these little legs that are here, they tend to actually break off and enter circulation and become embolic events themselves. So a lot of lawsuits on it, and they're kind of falling out of favor. All right, guys, this was long, so I appreciate your attention during it. Thank you so much.